So this is the last chapter of week 1. This is chapter 13. This goes through vital signs and monitoring devices. Again, a lot of this stuff we will go through again in our first lab night, our skills night, actually taking vital signs, getting some practice with using the equipment, so on and so forth. So we will go through the normal ranges of each of the different vital signs that you should be getting with every patient as well. So gathering signs, taking them, and looking over the monitoring devices. So what is a vital sign? Well, it is a huge component of every single assessment that we do. And it does take a few minutes to complete. Even when you do get really proficient at it, to do it correctly, it takes a little bit to do. Vast majority of patients should always have an assessment that includes vital signs. Now, that being said, every once in a while we get patients that aren't super happy that we're there, and they don't necessarily want us to put a blood pressure cuff on them. In those situations, even though we say aren't given permission to physically touch the patient, we can do things like look at their respiratory rate, look at their skin condition, and still get at least a few vital signs from the patient, right? You can tell a lot by respiration rate and skin condition on patients. When we take vital signs, we always want to take at least 2 sets. That way we can kind of start to get what we call trends within the patient's conditions. If our patient is trending upwards or trending downwards, it kind of dictates how aggressive we want to be with our treatments. And it can also tell us how our treatments are affecting the patient, hopefully in a positive way, right? So what are vital signs? Well, they're outward signs of what's going on inside the body. So in the last chapter, we talked a lot about pulse and we talked a little bit about respiration. There's a normal standard range at which a normal adult should be in as far as their pulse. So 60 to 100 beats per minute is considered to be normal for a pulse rate. Now, I am sure you guys are all aware that, normal is not a super accurate term. Everybody is slightly different. Normal resting heart rate for me might be in the 70s, which is in that normal quote unquote range of 60 to 100. But you might take someone who is super physically fit, like a marathon runner, peak physical fitness. Their pulse rate might be in the 50s, and that might be normal for them. So with all of our normal ranges, we do want to take in consideration that everybody's normal is slightly different, and even if it's outside of what the textbook considers normal, it may be normal for that patient. Everybody is different and in different physical stages within their life. So we want to think critically about what vital signs we're getting. If we took someone who's maybe in their 70s, who doesn't feel well, their skin condition is super pale, they've been feeling really lightheaded and dizzy, and you get a pulse in the 50s, that's a low heart rate. We're going to consider that to be abnormal for the patient and probably the cause of the symptoms that they're experiencing, right? Respiration, we're looking at about 12 to 20 breaths per minute for a normal adult. Again, a little bit faster, a little bit slower. As long as it's within reason and our patient isn't symptomatic, we're okay with that. Skin color, temperature, and condition. So we want to look at skin. We'll actually touch it and see if there's good capillary refill. Really accurate capillary refill in adult or in children. As we get older, our capillary refill just naturally starts to slow. So it's not as accurate in like older adults as it is in kids. But if all of you were to do this right now, just take the back of your hand, press the thumb of your opposite hand on the top of your other hand. If you press slightly, there should be kind of a flash of white, and then it'll go back to your normal pigmentation color, right? How fast it goes back to your normal color is reflecting the perfusion that you have. It should be less than 2 seconds for normal perfusion. And again, if you take somebody, say she's a person in her 90s, and you do that and it's say 3 seconds, that still may be normal for that person because of their age. So we want to take that into consideration as well. Pupils, How we check pupils is we're going to shine a little bit of light in the patient's eye, usually just right off to the side. And we should see some constriction and dilation back to normal with our pupils. They should be equal, round, and reactive to light. Blood pressure, normal blood pressure for an adult in your textbook is listed as 120/80. Fun little fact, when they were deciding what a normal blood pressure would be, they took about 20 guys of varying ages, but about 20 guys, took their blood pressure, averaged them out, and said this must be normal. And they got 20/80, 120/80. So lots of things flawed with that. It's 120/80 isn't a bad blood pressure. They are finding now and doing a lot of research now that if you are consistently at 120/80 for the duration of your life, it can potentially be damaging towards the end of your life. So the lower your blood pressure is, the better off you are for the duration of your life. That being said, there is a limit. Too low is bad as well. So everyone's blood pressure is slightly different. Anywhere from 100 systolic to 120 is around normal, and that's pretty good. If you start getting patients with blood pressures in the 130s, even to the 140s, oftentimes we can contribute that to whatever stress they're in that moment. They call it white coat syndrome, even though we don't wear white coats. It's a very similar idea that just being in a situation where you have to call 911, most of the time your blood pressure is going to be a little elevated anyways. Yeah, oxygen saturation technically is not listed as a vital sign. That being said, your SpO2 or your oxygen saturation is something that we usually get on every single patient, just to get a good baseline set of vital signs. So in total, there are 6 vital signs that I want you to get on every patient, right? Pulse, respiration, skin condition, pupils, blood pressure, and oxygen saturation. Oxygen saturation, normal range is going to be 94 to 100, or excuse me, 95 to 100. We don't treat until it's lower than 94 or symptomatic. So your baseline set of vital signs are going to be your first set of vital signs that are obtained. Repeat are going to be any vital signs thereafter. And then we do want to take at least 2 sets to get those trends established. The more vital signs you get on patients, the better your trending is going to show changes. So when we check pulse, we want to place our fingertips over that artery and then count for a minute. Counting for a minute is going to be the most accurate, but who's got time for that, right? To count for a whole minute. So the most reasonable difference would be to count for 30 seconds and then times that number by 2 so that you're still getting a minute rate. So say if you take a pulse for 30 seconds and you get 40 beats in that 30 seconds, you're going to times that by 2. The pulse for the whole minute would be 80. Right? Now, there are certain disciplines that will allow you to cut that in half and go like count for 15 seconds and then multiply it by 4, or count 10 seconds and then multiply by 6. All of that, the more you decrease the amount of time that you're actually counting, the less accurate your number gets. So for this class, I want you all to take pulse for 30 seconds or a minute, and then times it by 2 if you need to for that 30 seconds, all right? When we're checking a pulse, we're checking the rate, rhythm, and quality. If you guys were all to check your pulse right now, it should be a fairly strong beat. It should be very consistent, right? You shouldn't have any big jumps or any beats that are speeding up or slowing down. And then again, we're getting that number of beats per minute. Anything over 100 beats is considered tachycardic. Tachy meaning fast, cardia meaning heart. And then anything below 60 is considered to be bradycardic. Brady meaning slow, cardia or cardiac meaning heart. Anything over 150 beats per minute or below 50 beats per minute is considered a serious and significant finding. Getting 150 beats per minute, even just counting it, can be really difficult. It is unusual, and we may have to use electrical intervention, medication invention to intervention to change the heart and how it's beating. That's something that paramedics can do. So you would probably need to call ALS, your local ALS, for that, or just get them to the hospital really quick. Just talked about that. Anybody under a year, we want to check that brachial artery. So we're going to be placing our fingers over the bicep and checking their pulse there. Oftentimes, babies' pulses can be really quick, so it may be difficult to determine an exact number. Sometimes we do it where we're checking a pulse with one finger and then tapping it out with the other so that there's another person that's capable of helping you count the beats. Then we've got our carotid pulse that we already talked about as well. Oops. There we go. Carotid pulse, that's on your neck that you're going to feel. You can feel it on either side, just only do one at a time. We never want to check both sides at the same time. Respiration. So the way that we figure respiration is very similar to the way that we figure out pulse rate. We want to go by how many breaths they are breathing in a minute. 12 to 20 is the normal range for adults. And I want you guys all to do this here. I'm trying to prove a point here, but if you all just think about your breathing, if you just find a clock somewhere and try and count your own respiratory rate, you'll notice that as soon as you start thinking about breathing, you mess up your normal breathing pattern, right? It's something that normally is autonomic or automatic. And all of a sudden you're thinking about it, you're breathing too slow, you're breathing too fast, and you just kind of mess things up because you're thinking about it. The same thing happens with our patients as well. If we say to our patient, hey, I'm just looking at your chest right now to evaluate your breathing, they're immediately going to go, oh my gosh, am I breathing too fast? Am I breathing too slow? Why am I breathing like that? That's weird. Why am I taking deep breaths? I need to breathe shallower. No, I need to breathe more because that was too shallow, right? And they just automatically just start messing with their breathing rate. We don't want that. We want to get an accurate representation. I'm going to tell you a trick that will probably now not work for any of you when you're actually in class doing this on your classmates, because now everybody knows what you're doing, but it works really well on patients that don't know what you're doing. So what we do is we typically will go, oh, we're going to take your pulse here. If it's okay, I'm just going to hold on to your wrist. And when you hold onto your wrist, find their pulse, and then kind of look up or glance up to their chest and count their breathing for 30 seconds, and then count the pulse for 30 seconds. You got to remember the numbers, but say you get your breathing rate of 6 in 30 seconds, and then a pulse rate of 30 in 30 seconds. You now have a breathing rate of 12 and a pulse rate of 60 over the minute. All right. And they think you're taking their pulse, so they're not really thinking about their breathing. It does tend to work pretty well. Physical condition, age, sex, all kind of, and emotional state, all kind of affects breathing rates. Again, if it's around 12 to 20 and our patient is not symptomatic, we're going to consider it to be pretty normal. Breathing at a rate of 12 or 10 versus a rate of 22, it's still pretty normal, right? If you're talking a lot, that changes your breathing rate as well. If you're freaked out or nervous, that usually elevates it. If you've got somebody that's been drinking a lot of alcohol or has been smoking quite a lot of weed, that will lower their breathing rate as well. The more relaxed they are, it'll go down. When we classify our breathing quality, we look at things like normal, shallow, labored, or noisy. So shallow breathing, you all know what that is. Labored breathing is just working really difficult, working really hard to breathe. It's difficult to breathe. And then noisy would be like gurgling or snoring or any sort of additional noise that's happening while you're breathing. If you observe irregular respirations in an unconscious patient, you should definitely report it and document it. Irregular respirations in an unconscious person can mean a few different things. It could be head trauma that's causing changes to their breathing pattern because their brainstem is getting smushed. Or it could mean that they are taking agonal breaths, which are these big kind of gasps that happen right before you die. So that's pretty significant. And again, we're taking breaths for 30 seconds and then multiplying it by 2. Skin condition. When we're looking at skin, we want to look at color, temperature, and condition of the skin. Regardless of pigmentation of the skin, you should be able to see if someone is pale, if they've got jaundice. If you are having a hard time determining whether or not they are pale or jaundice or off color in any way, you can look at the whites of eyes or the gum tissue. That can tell you a lot, the inside of the mouth, that can tell you a lot about the condition that the patient is in. Nail beds are another one. Abnormal colors, pale. Cyanotic is a blue-gray color that happens when patients don't have enough oxygen. Flushed, that can happen for a number of different reasons. It's kind of a red coloring, usually found in the face. Jaundice is a yellowing that happens when the liver is acting up or failing. Typically, people get jaundice in their eyes first, which is why it's a really good place to check. But they can be jaundice all over. Temperature is another thing that we want to check. This is something we've been actually really good about since COVID. During COVID, they kind of implemented this rule that we were always to check a temperature on every single patient before we brought them into the hospital. And now we've just gotten into the habit of it. So temperatures are really easy to take, right? We're not doing anything crazy like a rectal temperature, just either the ear probe or the mouth or the forehead thingy. And we just want to see what they're at. Are they super cold? Are they super warm? Anything in between is probably fine, right? We can check with the back of our hand. I mentioned this in a video earlier that I don't really like touching people because people in general can be kind of gross. So I try not to do that. I'll use the equipment. But if you go, you can, if a patient is feverish, you can feel it through the gloves as well. If you go to like help lift them up, you can feel if their skin is really warm just by getting close to them. I'm not a germ freak, I swear. I just have seen a lot of really nasty patients. And that sounds kind of mean, but like once you find people that are like actively living with maggots, like increases of their skin, it just scars you. So please don't think I'm a horrible person for saying those things. I've just experienced some really bad situation. Necrotic toes, like toes that are literally dangling off of somebody's feet. It's just bad. Pupils. So that last slide that I skipped through, we had already talked about. That was the capillary refill in kids. Pupils, we're looking at the center, the black part of the eye, the center of the eye. We're looking at dilation, constriction, size, reactivity. Did it happen quickly or was it kind of slow or sluggish? Did they both do the same thing or is one different than the other? And we do this just kind of off to the side of the patient's eye. The brighter your light is, the more gentle you want to be with the patient. You don't have to get super close. Pen lights used to be super common that we were using those. Now everybody's got a cell phone with a flashlight on it. So oftentimes we're using our cell phones. Those lights though can be really bright. So just make sure that you're being gentle and just kind of going off to the side of the eye. We don't want to blind anybody. So this first image here, the one on top, is of constricted pupils. So that's really tiny pupils. That happens when you shine a light in somebody's eyes. It also happens with certain drugs. Heroin, for one, will constrict pupils. Dilated pupils, this will happen in darker environments naturally, or if you're doing substances like weed or alcohol, that will naturally just kind of dilate your pupils. Unequal pupils is really bad. We don't like unequal pupils. This is indicative of a head injury, some sort of brain trauma with increased pressure within the skull, and it's causing some big issues, right? This patient, if you see unequal pupils, they are not okay. Now, that being said, there are patients out there that naturally have unequal pupils. It's almost never this dramatic. It'll be, a millimeter or two difference between the two pupils, and it's normal for them. Typically, that's diagnosed really early. It's called anoscoria, and they will know that they have it. So if you are assessing a patient that has it, feel free to ask. if they've got an issue. I've also met some patients that have pupils that are offset. They're like not in the center of their eye. If that's not normal for them, that's a bad thing. But again, usually that's discovered really early, and they know about it. So just ask them if it's normal for them. Here's a good example of unequal pupils. Again, eye drops can cause this. Different chemicals can cause it as well. If it's happening resulting from trauma, that's when we're really worried. Blood pressure. So this is the force against the walls of the blood pressure in systolic blood vessels. Words. I've been lecturing all day, it feels like, so I'm starting to get tired here, but let me rephrase. The force of blood against the walls of the blood vessels is blood pressure. Systolic pressure is created when the heart contracts. So that's the active pressure. That should be the one that's higher. And if it's not higher, you probably took it wrong. So that one should be higher. And then diastolic pressure is what pressure remains in the arteries when everything is nice and relaxed. So normally that should be 120/80, but everybody is just a little bit different, right? The big thing is the numbers shouldn't be the same, and there should be at least a little bit of a gap between the two. If you took a pressure that was 120/100, that means that those vessels are incredibly like just under stress. It's always a high pressure environment, and that's not a good sign, right? When we're taking blood pressures, we're taking blood pressures with something called a sphygmomanometer. It's a blood pressure cuff, right? There's a few different ways that we can take blood pressures, and we will go through this in our skills day. So if you're not catching on to what I'm saying, that's fine. There's a gauge that measures millimeters of mercury of pressure in the cuff. You always want to put the cuff over the brachial artery. There are arrows on the front. Make sure that it is the appropriate size for your patient. We don't want to be using a adult cuff on a pediatric patient, right? That'll give you some skewed numbers. We're going to use our stethoscope, place it around the artery, and then pump up the blood pressure cuff. You will start, once the artery is under some stress, you'll start to hear the pulse. Typically, we're going to go, with our average patients, we'll go all the way up to about 180 or 160, and then we'll slowly release the pressure on the cuff. Once you're at the top, say 180 or 160, you shouldn't hear the pulse. If you do, you want to go even higher. It means their systolic blood pressure is higher than 160 or 180, right? So you'll go until you can't hear it. Once you're at the point where you can't hear it, so we'll say 160, you're going to slowly release the pressure in the blood pressure cuff, listening for the heartbeat. As soon as you hear the heartbeat, say it's 120, that's your top number, that's systolic. You'll hear the heartbeat until you can no longer hear it. When you can't hear it, that's your bottom number, so 80 or 60 or whatever it is, right? That's your normal manual blood pressure. And I'll teach you a few alternate methods in class, but that's one I want you to stick with for right now. That's just talking about what I just talked about. With pediatric patients, it can be difficult to get a blood pressure. As long as they've got adequate perfusion and a good pulse, we don't typically get too concerned about it with babies. Core temperatures are kind of the gold standard for taking temperatures. That would be like a rectal temperature. That's not something that we do in EMS outside of the hospital. The hospital will do it, but we don't typically. So there is a special thermometer that they use. Not necessarily that it's a specialized piece of equipment, but it's designated as a rectal thermometer so that we're not then using it orally on the next patient, right? Hopefully that makes sense. Most ambulance services don't carry two, they'll only carry one or two of the same kind. Temperature does depend a little bit on time of day, activity level, age, where it's measured. If it's going into the mouth, typically it is a little bit different from your core temperatures. Same thing with the one that goes across your forehead. Typically that's going to read a little lower than what it actually is if you go in the core temperature. Monitoring devices, our SpO2 sensors are super common. This is something that we put on pretty much every single patient. It doesn't hurt. It doesn't take really any effort. It's this little monitor that you place over the patient's finger. You turn on the machine and it spits out a number. That number, the SpO2 percentage, is a percentage out of 100 that's measuring kind of how much oxygen is in the red blood vessels as it goes past the sensor. There are flaws with this, don't get me wrong, but it is usually a really good place to start. Now, I always want you to remember that you're going to treat your patient, not the numbers. So even though it says 98%, if your patient is struggling to breathe, we're going to give them oxygen. All right, we never want to withhold oxygen from a patient. All right. Normal is 96 to 100. Mild hypoxia or lack of oxygen is 95 to 91, and so on down the line. Anything less than 94, we're going to give oxygen to, and we're never going to withhold if a patient is having some difficulty breathing. There's a lot of different things that kind of affect the accuracy of these numbers. Things like really cold fingers, excessive movement, nail polish, anything that will make it harder for that beam of light to read through the finger. Blood glucose. So this is what I consider to be a bonus vital sign. This and temperature, I call them bonus vital signs. Blood glucometers measure the quantity of glucose in the bloodstream. It can help identify diabetic emergencies, but people who aren't diabetic are still subject to diabetic-like problems, hyper or hypoglycemia, right? If you've got somebody that's fasting for, say, a religious reason, they may end up with low blood sugar, even though they're not a diabetic. So this is something, anytime I get a patient where it's like, we just can't figure out what's going on, they just don't feel quite right, I do ask if I can check a blood sugar, just because it can tell us quite a lot about the patient. And it's one more tool in our tool belt that we can use to narrow down what's going on with the patient. Normal blood sugar, again, incredibly subjective, depending on the patient. Normal range is 60 to 120. The reason it goes to 120, most hospitals say 100. That's because most hospitals get fasting blood sugars. Our patients mostly aren't fasting. So if I just drank a Mountain Dew and now you checked my blood sugar, it's probably going to be high. But that's still normal, right? I just drank a Mountain Dew. So using these glucometers, they come with lancets, the actual glucometer itself, and then strips, alcohol wipes, gauze are all in there. We want to get a blood sugar, a capillary blood sugar from a finger. You can use the heel on patients that maybe pediatrics would be the big one, but like if they don't have fingers or something like that, you can use the heel of their foot. You're just wanting to get capillary blood that you're taking a sample of and then putting through the glucometer, and then it'll spit out a number. We'll go through the specifics of this in our skills class. The next few slides are just kind of telling you how to take a blood sugar. So like I said, we'll go through that in our skills class. Alrighty, this wraps up this week worth of lectures. I will have week 2 up hopefully sometimes this week, now that I've got the video glitches kind of figured out. And expect the section exam to open up here shortly as well. I'm still working on getting that created. I kind of revamped it for this class. So alrighty, as always, feel free to contact me with any questions.